Guia de estilo e instruções para síntese de fala. Início das instruções. Você é um narrador, palestrante com voz potente, forte e autoritária. O tom deve ser firme e inabalável. Este H comece com energia total e um tom de comando, capturando a atenção imediatamente. I remember the afternoon a woman in her late 60s sat down across from me, held a folded piece of paper with grocery lists and doctor names, and said, "Doctor, I walked into the kitchen and I couldn't remember why I came. It happens more these days." Her hands were steady, but her eyes searched mine for something between explanation and reassurance. That kind of moment is why I want to talk plainly about one of the most treatable contributors to memory problems we see in people over 50, vitamin B12 deficiency. My aim is to explain how it can affect thinking, how we test for it, what treatment paths look like, and simple habits you can use right away without scaring you and always encouraging you to work with your clinician. If you find this useful, stay with me through the practical steps and the short checklist I'll offer for your next visit. If it helps, please subscribe, tap the notification bell, and leave a like so we can make more clear, practical guides like this. Now, let's get into what B12 really does in the nervous system and how that connects to the little lapses you may be noticing. A quick medical note before we move deeper. This is educational information and does not replace a personalized evaluation. If you're worried about symptoms, please consult your clinician. Timelines and responses to treatment vary, and you should not self-prescribe or self-inject treatments without medical supervision. Think for a moment about the wiring in an old house. Over time, wires accumulate dust, insulation wears thin, and the lights might flicker before they go out. In the nervous system, vitamin B12 helps maintain the insulation around nerve fibers, a fatty layer called myelin. When B12 is low, that myelin can fray, and signals that used to travel cleanly become slower or noisy. On a practical level, that can show up as the fuzzy feeling when a name won't come, short episodes of forgetfulness, or slowed thinking. I like the garden image too. Imagine the brain as a garden where soil quality, water, and pruning matter. B12 is one of the nutrients in the soil. Without enough, a few plants struggle. With attention and time, soil amendments and tending can help some things grow back stronger. But recovery is gradual and depends on how long the deficiency has been present. There are multiple reasons someone over 50 might develop low B12. As we age, the stomach tends to produce less acid, a change called hypochlorhydria. An acid helps release B12 from food. Certain medications commonly used in older adults, such as some acid-reducing drugs, can reduce absorption. Autoimmune conditions like pernicious anemia block the intrinsic factor the gut needs to absorb B12. Surgical histories that alter the stomach or small intestine can impair absorption as well. Dietary patterns matter too. Strict vegetarian or vegan diets without adequate B12 sources or supplementation can lead to deficiency over years. Chronic gastrointestinal disorders, including celiac disease and inflammatory bowel disease, can also interfere. It helps to think of these causes as a set of levers: diet, stomach acid, intrinsic factor, and intestinal surface, any one of which can tip the balance. Let me tell you about Mrs. L, an anonymized vignette you may find familiar. She was 68, lived alone, and kept a small garden outside her apartment where she grew tomatoes and basil. Over several months, she noticed growing music on the radio that she could not recall the name of, and she mislaid items more often. Her daughter convinced her to come in. Her basic blood work showed a borderline low serum B12, and we ordered complementary testing: methylmalonic acid, or MMA, which rises when cells are starved of B12, and a complete blood count that showed a slightly enlarged mean corpuscular volume, MCV, the measure of red blood cell size that can hint at B12-related anemia. Her MMA was elevated, supporting a biologically relevant deficiency. We talked about options, started treatment under supervision, and over months she reported that she could recall the names of plants again and felt less absent in conversation. Her cognitive gains were incremental. Not every day felt the same, but the trend upward was real. Testing for B12 deficiency can feel opaque, so I'll walk through what we commonly use and what the results typically mean. The first step is a serum B12 level. It's a simple blood test, but it has limits. A low serum level suggests deficiency, while a clearly high level makes deficiency unlikely. The challenge lies in the borderline zones. That's where additional tests come in. Methylmalonic acid, or MMA, is a metabolite that accumulates when B12-dependent processes lag. An elevated MMA supports that tissue-level deficiency. Homocysteine is another metabolite that can be elevated with either B12 or folate deficiency, and sometimes with other conditions. It's useful but less specific than MMA. Some labs offer active B12 testing called holotranscobalamin, which measures the fraction of B12 available for tissues. A complete blood count with attention to MCV can show macrocytic anemia, larger red blood cells, which often accompanies B12 deficiency but can be absent in purely neurological presentations. Taken together, a low serum B12 plus an elevated MMA is strong evidence supporting deficiency. A borderline serum B12 with normal MMA might prompt observation or repeat testing depending on symptoms. Whenever results are ambiguous, the sensible route is shared decision-making with your clinician rather than assuming a diagnosis from a single number. Once we establish that treatment is needed, there are two broad approaches commonly used: high-dose oral supplements and intramuscular injections. That same relief is often modest and cumulative. Families often notice subtle shifts before patients do. Interpreting ambiguous labs is a common source of anxiety. Imagine lab values as pieces of a puzzle rather than a single decisive tile. A low serum B12 plus a high MMA forms a clearer picture of deficiency. A borderline serum B12 with normal MMA might be watchful waiting, dietary adjustments, or a trial of supplementation depending on symptoms and risk factors. If pernicious anemia is suspected, tests for intrinsic factor antibodies and parietal cell antibodies may be pursued. Always discuss the pattern of tests with your clinician, because labs are context-dependent and individual decisions matter. There are safety considerations for certain groups. If you have multiple medical conditions, for example kidney disease or complicated blood disorders, interpreting homocysteine or MMA can be trickier, and specialist input may be helpful. If you are taking medications for blood thinning or other chronic conditions, coordinate any changes through your prescribing clinician. And again, do not self-administer injections without clear instruction and supervision from a healthcare professional. Before I summarize, here's a practical script you can bring to your clinician if you're concerned. I've been noticing more frequent memory lapses, for example, walking into a room and forgetting why. My medications include blank. I eat blank. Note if vegetarian, vegan. Could B12 deficiency be a contributor, and which tests would you recommend? If tests show deficiency, what treatment approach would you suggest given my history? That short script helps frame the visit and ensures you get the testing most likely to be informative. As we move toward a close for this segment, I want to underscore the hopeful yet realistic message. Recognizing potential B12 deficiency gives you a concrete, medically supervised path forward. It's one of the reversible contributors we can test for and treat, And while recovery is often gradual, many people experience meaningful improvements in attention and memory when deficiency is corrected and supportive lifestyle measures are adopted. Next time, I'll walk through how to read common test result patterns in more detail and the specific questions to ask when a clinician recommends a particular treatment plan. If this discussion has raised questions for you or someone you care for, hold on to those notes and bring them to your clinician. In the meantime, try a simple habit, the smoothie I described, a 10-minute walk, or a brief sleep routine, and see if consistency changes how you feel over the next few weeks. We'll pick up with interpreting lab patterns and shared decision points in the next segment. Let's take that promise seriously and walk through the common lab patterns you will see, what they likely mean, and the practical questions to ask when a clinician recommends a treatment plan. Common test patterns and practical interpretation. Low serum B12 with elevated methylmalonic acid and elevated homocysteine. Interpretation. This pattern is the most straightforward biochemical signature of true B12 deficiency. MMA is relatively specific for B12. When it rises along with low serum B12, the case for deficiency is strong. Practical action. Treat the deficiency while also pursuing the cause: diet, medication effect, malabsorption, pernicious anemia. Ask whether immediate parenteral therapy is warranted, or whether a trial of high-dose oral therapy is reasonable. Borderline low normal serum B12 with elevated MMA. Interpretation. Early or functional B12 deficiency. Serum B12 alone can be misleading. An elevated MMA in this context supports a diagnosis even when B12 sits near the laboratory's lower limit. Practical action. Unless another cause of elevated MMA is evident, a trial of supplementation is usually prudent. Discuss follow-up MMA to document biochemical response. Low serum B12 with normal MMA and normal homocysteine. Interpretation. This can represent false low serum results, laboratory variation, recent oral intake changing levels without tissue repletion, or a non-specific low value in the absence of metabolic deficiency. Practical action. Consider repeating tests, checking MMA if not already done, and assessing symptoms and risk factors before committing to long-term therapy. Normal serum B12 with elevated MMA. Interpretation. A classic flag for functional deficiency, common with long-term metformin, prolonged PPI or H2 blocker use, nitrous oxide exposure, or early pernicious anemia. Because MMA's rise often precedes a fall in serum B12, this is important to recognize. Practical action. Investigate medication history, consider stopping or adjusting offending drugs if possible, and typically treat or at least closely monitor while addressing reversible causes. Isolated elevated homocysteine with normal MMA. Interpretation. Homocysteine rises with either folate or B12 deficiency and can be affected by renal function and certain medications. If MMA is normal, folate deficiency or other causes are more likely. Practical action. Check folate and renal function. Interpret homocysteine in context. Key diagnostic steps beyond the numbers. Test for pernicious anemia if suspicion exists. Intrinsic factor antibodies are specific but not perfectly sensitive. Parietal cell antibodies are more sensitive but less specific. A positive intrinsic factor antibody test strongly supports lifelong B12 replacement. If antibody testing is negative but clinical suspicion remains high, Further evaluation, including endoscopy with biopsy in some cases, can be considered. Consider other causes of malabsorption: prior gastric surgery, ileal disease, Crohn's disease, small intestinal bacterial overgrowth, or medications that reduce acid or alter absorption. Check renal function when interpreting MMA and homocysteine because kidney disease can raise these metabolites independently. Treatment decision points: oral versus parenteral. Severity and urgency of symptoms. Progressive neurologic signs, for example, sensory ataxia, pronounced paresthesias, significant gait impairment, usually justify prompt parenteral therapy because the intramuscular route guarantees bioavailability and may be preferred when rapid correction is desired. Severe anemia with hemodynamic compromise also leans toward parenteral therapy. Cause of deficiency. If malabsorption is clear, post-gastrectomy, ileoresection, chronic severe PPI use with evidence of impaired absorption, many clinicians choose intramuscular injections. In pernicious anemia, lifelong replacement is required. Both high-dose oral, example 1,000 to 2,000 milligrams day, and intramuscular regimens are effective, but injections are commonly recommended initially for convenience and assurance of dosing. Patient preference, logistics, and safety. Some patients prefer oral therapy to avoid needles. High-dose oral therapy is effective in many cases, including some with malabsorption, because a small fraction is absorbed by passive diffusion at high doses. When choosing oral therapy, establish a clear plan for early biochemical and clinical follow-up. Typical treatment regimens and monitoring. Parentero, common approach: 1,000 milligrams intramuscularly daily for 1 week or every other day for 2 weeks, then weekly for a month, then monthly maintenance. Variations exist and clinicians tailor to the case. This schedule rapidly corrects stores and raises hemoglobin if anemia is present. Oral high dose. 1,000 milligrams daily is commonly used. Some protocols use 1,000 to 2,000 milligrams daily for several months. This is generally safe, well tolerated, and effective for many patients. Monitoring. Hematologic response, reticulocyte count within 7 to 10 days, and improvement in hemoglobin over weeks. Symptom and neurologic reassessment. Check MMA or serum B12 at about 2 to 3 months to document biochemical improvement. If symptoms fail to improve or worsen despite biochemical correction, seek specialist input, neurology or hematology. Safety and special considerations. Large therapeutic doses of B12 are safe for most people. Toxicity is rare. Coordination with other medications, especially anticoagulants, should occur through the prescribing clinician. Rapid hematologic recovery can unmask low potassium in rare cases. Monitoring electrolytes in severe anemia is a reasonable precaution. Pregnant and breastfeeding patients. B12 is important for fetal neurodevelopment, address deficiency promptly, and coordinate obstetric care. When pernicious anemia is diagnosed, consider screening for other autoimmune conditions, for example, autoimmune thyroid disease, as clinically indicated.